So I'm going to be talking a little bit about the treatment for peripheral arterial disease. Now, one of the questions I'm asked more often than anything else is, you're a vascular surgeon, so you treat veins, right? And the answer is yes, we treat veins and we treat arteries. Arteries, veins are both within the vascular system, and we treat both of them. Today, we are going to be talking about peripheral arterial disease, but it's all part of the same system. Your arteries take blood down to your legs use it, and then the veins return it back to your heart. So here we have the arterial system of the leg. Don't try to read any of those. It's extremely complicated, and there are a lot of little vessels. But we don't see this. What we see when we do angiograms is this. So when we give contrast into the artery, the contrast mixes with the blood, and then under the X-ray camera, we watch the contrast go everywhere the blood goes. And what this lets us do is basically take a picture of the inside of your arteries. So if there's a blockage or if there's narrowing, we can see it. And here we have the main artery of the leg. This is the superficial femoral artery. And as we go below the knee, you see the three vessels that Dr. Gopal was talking about. These are in the calf. As we go further down the leg, we end in the foot, and we see all the vessels in the calf kind of meet together, and they branch out into the very fine vessels of the foot. Now this is an artery that's diseased. You can see here about halfway down, the artery gets very, very narrow. And then as you go further down, it doesn't get quite so narrow, but it doesn't look like the strong ribbon that we just saw in the previous pictures, right? This is an artery that has disease. This is what we call a stenotic artery. Even though you can't see the plaques, you can see the blood going around it, right? You can see the areas in that stripe that are ragged. You can see the areas where it's narrow. So that's what we're looking at when we do an angiogram. Now sometimes the artery is blocked completely. Now our ribbon is not only somewhat thin, it's missing. It's missing in the last third of this person's thigh. You can see the blood just stops. And you can see these smaller arteries. Sir, I think what your physician was talking about is your body growing its own bypasses. What happens is that all of the small arteries in the leg, as this blockage keeps blood from going down the main artery, these little tiny back roads, think of these as back road arteries, and the big one is kind of the highway. The blood can't go down the highway, so it goes down these back roads, and these back roads are winding, and they can't handle a lot of traffic, and it's not very fast, but it's all your body has. And when this is the case, very often when you're at rest, like Dr. Lilly said, you're not feeling any pain. You're sitting there, your leg's fine. But what you don't know is that your leg is basically living paycheck to paycheck, right? You're just standing there, it's getting just as much blood as it needs not to hurt when you're sitting there. As soon as you get up and try to walk, well, it doesn't have enough to spend to walk, and that's when you get the pain. So there are a bunch of ways that we can treat this without necessarily doing a bypass. Now, all three of us are vascular surgeons, and when you think surgeon, you think a knife, and you think stitches, and you think being in the hospital for 4 or 5 days. But what Dr. Gopal said is absolutely true. Technology has come a long way in the last 10 or 15 years, and I would say a majority of vascular surgery in this particular condition in this country now is actually done with only a needle stick, wires, catheters, balloons, and stents. So the same condition which 20 years ago would have been treated with a bypass can now be treated with a stent or a balloon, and you can be home the same day or the next morning. So I'm going to talk a little bit about some of the methods we use. The first one is an angioplasty, and this is actually pretty intuitive. You've got an area of narrowing, we put a balloon in that area of narrowing, and then we blow up the balloon. That makes sense to anyone. Your area of narrowing is now much bigger. Your artery is able to allow much more blood to flow where it wasn't allowing very much before. Now the problem is that sometimes, depending on the artery and the patient, this doesn't last for very long. And by very long, I mean 6 months or a year. So one of the other things this is an artery before ballooning, and that's the artery afterwards. So you can see it really can make quite a difference as long as it works. Now, as I said, it doesn't last very long in all patients. So what was invented is the stent. Now, I know that most, if not all of you, have heard about stents in the blood vessels in the heart. And these are the same thing, they're just bigger. Okay? They're bigger because the arteries in your leg are bigger than the arteries in your heart. And the reason they're bigger is because your leg is bigger than your heart. If your leg isn't bigger than your heart, you have bigger problems than I can fix. So this is a stent as it's being deployed. And the reason I put this picture here is so that you can understand how a stent, which can be quite big, it can be almost a centimeter wide, can fit into a small catheter that is 2 or 3 millimeters. It's made of a wire mesh. It's made of a special alloy. It's made out of a nickel titanium alloy. And once we get it in position, we deploy it. And it goes from being very, very small to very big and very strong. And it holds that artery open. This is a cartoon of what it looks like when the stent's deployed. You can see, just like in balloon angioplasty, the small area, the area of narrowing, has been widened. But in this case, we have a stent that's actually holding it open. And this will last a lot longer than just a balloon. And this is an artery, as you can see, this is what we call kind of diffuse disease. There's no single area of blockage. There's no single area of severe narrowing. But the whole thing just doesn't look great. And this is that same artery after it's been stented. Now, this is something called atherectomy. I don't want to talk about this very much. In certain patients, in certain arteries, what we'll do is actually shave the plaque itself. Now, this is something that you may have heard talked about as roto-rootering. It's kind of a clumsy term, but it gets the idea across. We actually take the material that's blocking out of the artery rather than stretching and holding it aside. There are a number of problems with this that don't make it the best solution in all cases or in all patients, but it still does have its place. And the artery that I showed you before with that complete blockage was actually treated with atherectomy. And that's what it looks like afterwards. As you can see, it's nice and wide. There's a strong black ribbon. There's a lot of blood flowing down into the leg. And then finally, and I include this just because I think that this is going to be used more and more in the years to come, this is what we call a Viabon, which is a name for a stent that has some fabric on the inside. And the reason this is noteworthy is that before, remember I said 15, 20 years ago, everyone would have gotten a bypass. What this actually does is it lets you perform a bypass inside the artery. It lays that fabric tube inside the previously blocked artery, and it gives you a bypass without having any incision. It's kind of neat. Viabon. V-I-A-B-A-H-N. Right now, that's the only brand name for this particular kind of stent. It's not going to be that way forever. And here we have an artery. There you can see a complete blockage. And there it is with that particular stent deployed. So in sum, I know that I went through a number of methods, and while they may, in consideration, seem extremely technical, they're all intuitive. I really did explain to you exactly how each method works. And I promise you, if you think you understand, you completely understand what we're doing. So there are a lot of options. Which one we use depends on the patient. It depends on where the disease is, what kind of disease it is. And even with all the options that exist now, I promise you in the next 5 to 10 years, in the next 1 to 2 years, there are going to be more. This is an area of increasing technological development. Okay? The field is, at this point, being defined by what can be invented rather than what can be discovered. Which means that really the only limiting factor is ingenuity. And I think we've got a lot of that. And what I've talked about, it's just one method in a very, very large range of treatments. Open surgery is, for the most part, the most durable option, and in certain patients, the only option they have. Some doctors you may go to and they will say, well, I can't stent it, so there's really nothing I can do. Vascular surgeons are trained in open surgery and these techniques. So if we can't do it one way, we're going to do it the other way. And finally, maybe the main point of this is that every patient is different. Every artery within that patient is different, and every kind of disease that patient has is different. So if you know someone, if you have a brother or a cousin who had a vascular surgery done, there's no guarantee that the same surgery is right for you. But there is one that is more suitable for you than others, and in consultation with your vascular surgeon, we can probably find out what that is. Thank you.